There you go. We're on.
All right, this is Hillary and Wayne Struby with Family Acreage Health and Wellness. And we're going to be interviewing today Katie Schwarz, PT.
Ninja extraordinaire. That's right. Well, so what we're doing is, what's happening today?
So this is the season of surgeries. A lot of people met their deductible and they want to get their total knee done, total hip done. Any surgeries they're thinking of, they want to get it done now before the new year. And then you have Medicare that will refresh in the new year, and they're kind of looking into getting what they need to get done when the year starts.
And BT Dubs, right now it's November 20th-ish. Well, I don't even know what the date is, but 22nd. But that's the time of year. In case you're watching this like 10 years from now, it's the end of the year, and that's when everybody's trying to, their deductibles are met and they're ready to go crank down some surgeries. So that's what we're talking about right now. And Katie's been dealing with a lot of these, and she's an expert. But before we get into the meat and potatoes of this interview, Katie, why don't you tell us a little bit about yourself? You're like in what maybe freshman year, writing your new last name on your little thing, thinking about your future husband. So how did you become the physical therapy extraordinaire you are today?
Well, back in the day, I played sports growing up and tore my ACL in my junior year in high school during basketball. So had to go through the whole surgery, ACL reconstruction, several months of physical therapy. Some strange reason, thought it would be fun to torture people like my PT did. No, in all seriousness, I thought it was cool to see the process of how the therapist gained your trust in the beginning, worked with you all the way through the process, got you back to sport. Went back to sport, no problem, and so that's how I got interested in physical therapy.
Cool.
So went to school at Texas State in San Marcos and graduated there in 2013. Started a sports orthopedic outpatient setting for 4.5 years. Moved and had kids, and their schedule kind of needed a change in pace. So I switched to home health and have been doing that for the past 3.5, working on 4 years. And so it allows some flexibility in the schedule to be able to do drop off and pick up with kids.
Oh, kids.
Yeah, that's awesome.
Yeah. All right. Well, very cool. Very cool. So the first question.
So you're doing home health. What is the population that you normally treat?
Typically, I'd say most are Medicare, which usually means they're 65 plus. Occasionally, with all the post-ops that they're talking about, we will get like 50 something, occasionally a 40, who needs a total knee or a total hip done. But most are 65 plus. And I would say that 65 is still probably considered on the younger end of everything.
Yeah, definitely.
In home health.
All right. Well, what kind of surgeries do you see? I mean, just post-op surgeries. Yeah. Obviously, they're all post-op. Hopefully, you're not there during the surgery. So, post-op means after. Just to let you know, after surgery, post-operation. So a lot of people are like, "What's post-op?"
Yeah.
I was like that when I first started working as a student. What is that?
Well, and that's why we're here.
Yeah,
we're
so
going to provide information.
You got the guy that thinks that way. Like, dumb it down, this guy.
Here we go.
I'd say most common, definitely total knee, total hips.
Totally.
Yeah, totally. The whole thing. And usually some kind of lumbar or spinal surgery, like a fusion or laminectomy.
Like too many shoulders? Shoulders are not.
I don't see a whole lot of shoulders in home health, saw them a lot in the outpatient setting.
But that's usually like a fix, not a replacement, right?
I did see total shoulders in outpatient too,
Okay.
but it would be, they'd kind of let them sit for a little while before they would come in.
Exactly.
But,
Okay. They would be with home health or something like that.
Yeah. Mm-hmm.
Okay, cool.
And what would you recommend, before going to surgery that you would tell your patient or your family member, like things that they need to either do before or things to kind of expect?
Yeah.
Would that be called prehab?
Prehab.
I didn't make that up.
Maybe.
So Prehab, I recommend Prehab if it's an option. I know some people have been dealing with these things most people have been dealing with this pain for a long, long time, so they know it's something that they're going to have in the future, and they've probably been buying time through injections, activity modification, pain medicines, but a lot of people, and of course we all have biased opinion probably, a lot of people don't do a whole lot of prehab, which just means therapy before surgery. Going in with any increased strength, the best mobility that you can have before surgery is going to help make that process afterwards a lot smoother, and honestly kind of gives you an idea. The exercises you'll do before, you'll probably agree with this, the exercises you do before surgery are very similar to what you're going to do on that initial post-op total knee. So if you're familiar with the process of what you're going to be doing afterwards, it's a little less scary.
I don't know. Do insurances pay for that? I mean, would they allow prehab?
Some of them. I don't know.
Medicare? I'm not sure.
Yeah, I mean some of them, and I know you. And I don't really know what the cap is on Medicare. I know they only allow a certain amount, but honestly, in the home health setting, it's kind of I submit for what I feel is appropriate, and then sometimes they tell me,
You never know.
can't do that part. But
We're gonna interview somebody about that.
yeah, I can't
How's
wait
this
to do
gonna
that
work?
one.
Right.
Yeah. All right, so cool. Do I get the next question, Hillary?
Yes.
All right. Ooh, pain management. Like the level of discomfort with therapy, pain pills, this weird word named RICE, incision care. How does that all work? Oh,
Hi.
hold on a second.
Oh, can you let the doggy in? Oh, thank you.
All right, so let's start over on that. So let's talk a little bit about pain management. Kind of like what the patient's level of discomfort is, what they do during therapy, how do you just dig in there and hold them down and do it. Pain medications, how they deal with that, and then also like there's something called RICE. We need to figure out what that is.
Not the type you eat.
Not the type you eat.
Yeah. So everybody varies highly on kind of what their pain is after surgery, and that's a subjective thing. I think it's just personal to each person. A lot of people,
That's the camera.
I know, a lot of people come out, and I would say if everything goes smooth and you've got a good pain medicine regimen schedule already going, then I would expect moderate pain. But usually you'll be prescribed like a muscle relaxer, a pain pill, sometimes anti-nausea medication. If you can do that pain pill like every 4 to 6 hours initially for the first couple days, then start increasing that time. I know a lot of people use Tylenol in between to try to extend the dose or the time between pain medicines a little bit further. RICE, huge, is rest, ice, compression, and elevation.
Acronym, nice.
Yep, so obviously rest is important after surgery, especially in that acute phase, so first week or so. Elevating, I usually recommend for my patients to elevate 20 to 30 minutes several times a day. While they do that, I recommend that they put ice on for about 20 minutes. After 20 minutes, it's done what it needs to do. They can just take it off and reapply in another hour.
And then compression, they just use their belt and put it on there as tight as they can.
So a lot of times patients will come home with an ACE wrap, stretchy elastic bandage, if you don't know what that is, and it'll be around mid-thigh to if it's a knee, mid-thigh to mid-calf.
Okay. I have a lot of patients, I remember, and I don't like answering the question. They would ask me about, I tell them about RICE. They're like, well, I love heat. Can I put my hot pack on it, please?
There's tons of inflammation. Don't throw the heat on it.
Oh, so you don't want to throw more kerosene on the fire.
Right, exactly.
Okay.
Fuel the fire, yeah.
So if you think hot feels good, put it on your neck, as long as you didn't have surgery on your neck, and let your knee have the cold, all right? Little old ladies don't like cold.
Oh, no, they don't.
They get mad at you.
Nope.
All right.
All right, next one. So you talk about inflammation and that normal part of inflammation. What is the difference between that normal inflammation and things that people need to start worrying about?
Oh, like if they have an
Like
infection.
infection, right?
Yeah, so it's 100% normal to have swelling and inflammation all the way down into the ankles and toes after a total knee. I use this analogy for people because I don't think people understand how intense the surgery is, we'll put it that way. I usually tell them it's not delicate brain surgery, think of like construction work. Somebody building your house, there's saws, there's hammers, there's screws, and so usually when you tell them that, they feel a little bit better. But anyways, it's normal to have swelling, it's normal to have terrible discoloration or bruising all the way down into the foot, and that scares people to death.
They clamp you in so you don't move during surgery. They literally put a vice on your freaking leg so you don't move. And if you're a peach, they're gonna bruise.
Yep, and so I usually tell people, it's normal to have that. I'll tell them that exact same thing. They gotta position you on the table. When it's normal to have heat, it's normal to feel the knee and for it to feel hot. If there's inflammation, there's gonna be warmth. When you start getting concerned about it is if you have body aches, chills, fever, and it's fever of like 100 and above that you're sustaining that temperature and you're not able to bring it down. Red streaking up or down by the knee or on the leg. A lot of them come out with like the occlusive dressing where you can't see through it, so you can't really see if there's drainage or not. But
you can tell if it's draining underneath it though sometimes.
Yeah, so if there's like a lot of drainage and it's pus-like or it smells foul, those are all signs of infection.
Like a chicken?
Yeah, stinky.
We're close to Thanksgiving. That's gonna maybe turkey. Not that kind of foul.
So those are all signs to look for, and usually it comes on your discharge paperwork. I know sometimes you get thrown out the door when you have surgery and you.
Oh, and you're high too. You're freaking buzzing off your freaking.
A million questions.
And you're, like if it's the wife's husband, you don't care.
They're just worried about getting that person out of the car and back.
Like, how do I get in the car back in the house? So they are listed. So watch this video.
Yeah, I'll circle it on the
hit the subscribe button.
Yeah.
I'll circle it so they know, and they just have a list.
Yeah.
And it makes them feel better.
Very cool.
I'm just gonna add on just a little bit to that. Like, can you kind of hit up on the incision care, like with the infection and learning all that, and then just how to do like baseline incision care.
So initially post-op. A lot of the ones that I see come with that occlusive dressing, which means just a big waterproof Band-Aid basically with a cotton type absorption to soak up any drainage that does happen. Those usually will stay on for 2 weeks. They're intended to, so that when you go for your first post-op visit with the doctor, they take it off at that point usually. And then once the incision is healed, fully closed, there's no open spots on the skin, the incision care there, and maybe jumping ahead, I don't know, but the incision care there is to do some scar tissue massage. So I don't know
that
if
is
that's later, but
it's okay.
Adhesions can come up, but let's keep rolling with the rapid going.
Okay.
But I know that like if that bandage comes off, you let that surgeon know, because some surgeons are like crazy.
And each one has a different.
And some of them don't care. Like, take it off then, but some of them like, I take this thing off. I'm the one that's going to look at it. So you might want to let your therapist know that. Because we've been working home health as we have. We've gotten lit up.
Call the doctor and get an order. I would just call the doctor and get a verbal order to.
That's for therapists that are watching.
Whatever they want me to do. Some of them say, take it off, cover it with gauze and Medipore tape, just putting tape over it. If there's drainage, then do that again in another day or two. But I always call and figure out, because each surgeon is different. Some of them don't want you to touch, and they'll say, nope, send the person to the office.
And you want to keep that rapport going with that surgeon that you're working with. So.
I know a lot of people, when they do get their the big waterproof bandage off, if there's still like opening, like just small little scabs or stuff like that, I have a lot of patients who want to rub like Neosporin and all sorts of stuff on it. And that just introduces a route for infection, bacteria to get in there. So I usually have to educate, don't put anything on it unless you just keep it open to air, keep it dry. So does that answer the question?
No, yeah, definitely.
All right, sweet. It sounds. What's the? Oh, you already did it. What do you recommend for patients that experience the normal constipation? You know what I mean? After having anesthesia as well as taking pain pills, that all kind of just keeps backing you up, right? So, are there any concerns they need to watch out for, and how do they get it flowing?
Yeah. Okay. So most commonly with the patients I treat, we're seeing them usually, they have surgery, say on a Monday, come home on a Tuesday, and we'll see them Wednesday for their first visit. Normally they have not had bowel movement by that point.
And they're usually having like 1 or 2 a day.
Yeah, they're usually normal, everything's fine. So,
it's not just the knee that hurts.
and I've seen it where like it's just they can't get it going. But some things, a lot of doctors will prescribe like Colace or Docusate sodium, which you can get just at your pharmacy. And usually they'll recommend like 1 in the evening and 1 in the morning. And I tell my patients, as long as you're on narcotic pain medication, I would keep taking it. You can use Miralax, a dose of Miralax. If we're still, and that's usually what I tell them to start with, and if you're not getting another one in like a day or 2, then I tell them to do either magnesium citrate or milk of magnesia.
Magnesium's good stuff.
Always
you need
tell them
magnesium
to
anyway, right?
Take the low dose so that you don't end up with the opposite problem of sitting in the toilet all day long.
It's hard to turn the faucet off when it starts going.
And when you're in pain, that's always not a good thing.
Yeah. To the bathroom fast and you're
Up and moving helps too.
Yeah, walking around. But a lot of times I was walking somebody for the first time with after knee surgery, like, we gotta go to the bathroom.
Let's go. Let's go.
Yeah, that's usually the first stop. Oh,
One that I learned from nurses, I had never, prune juice can help. And that's, I would say if the severity is low, maybe use that. But a lot of the nurses that I work with say warm prune juice in a pat of like melted butter, real melted butter in the prune juice.
I guess so, yeah.
Sounds kind of like bulletproof coffee.
Yeah.
It'll
make sense, but like prune juice and butter.
I know. Like if you can stomach it.
Put a little butter in your coffee too. That'll. MCT oil in your coffee, you might have disaster pants if you.
You better be close to the bathroom.
Be close, especially if it's your first time to do it.
Yeah.
Or maybe just get set up in the bathroom and just drink
it
on the toilet.
Put your percolator there in the bathroom. All right, that's good.
Yeah, no, that's good.
Everybody's always worried about constipation. And if it lasts a long time, you better talk to a doctor. You might have.
Do you have a certain day time frame that if they haven't had a bowel movement that they need to contact their doctor?
I usually say if after about a week you haven't had one, then you need to contact the doctor. They may have you try enema or something like that, but I usually tell them. And I've seen it in patients. It's just they tried everything, nothing's working. Where they get like impacted, and it's only happened maybe once or twice that they feel like crud,
and it affects their therapy.
Yeah, their stomach's distended, it hurts, and usually that becomes more of the pain than the actual whatever post-op that they've had. So, it's a big issue.
I know a lot of people don't know this, so this is why we're bringing this information out there. All right, so blood clots.
Yes.
What do you tell people? Because you're having surgery, so you're prone to having a blood clot.
Yep, it's just a normal post-op risk. It scares people, I think, when you say blood clot.
Yes.
So they are fearful. A lot of times that's the first question I get when I come in. How do it hurts. Do you think I have a blood clot? And 99% of the time I'd say they don't. That's not a research statistic, so don't shoot me on that. So come in, and a couple things prescribed by the doctors. They'll either have like plasma flow or like just compression to the calf. So devices that you wear, mechanical pumps that anytime you're sedentary over the first 2 weeks, like if you're laying down in bed or if you're just sitting, they pump your calves to try to prevent any stagnant blood from forming a clot. Getting up every hour. I know it sounds crazy, but I tell people, they think, oh, every hour? If you nap, it's fine. Take an hour and a half nap, it's fine. But every hour, try to get up and move.
Every hour.
Even if it's one small lap all around the house and then you come back, it's going to help. Ankle pumps.
Yeah, what's the big deal about blood clots anyway? What do they do?
So
Why don't you want? They sound cool.
Yeah, they can cause a significant amount of pain and swelling in the lower calf usually, but they can dislodge, end up in your lung.
Oh, what's that called?
It's called a PE,
Which is
pulmonary embolism.
There you go.
And you can actually die from that.
Okay.
It's an emergent situation.
How do you know if you have a PE?
So if you get excessive shortness of breath, that's not going away. Like if you're just sitting there resting, you have excessive shortness of breath, dry cough. Those are, don't even bother calling your doctor. Don't call your home health agency. Dial 911.
it's like, don't call her.
Yeah, don't call me.
I can't get you.
You call 911 and you go to the hospital. So,
Okay.
yep.
And then you mentioned the calf. What is the blood clot in the calf? Like, what is that called?
That's the DVT, which is deep vein thrombosis. It just means a clot in a deep vein. Some doctors don't use the mechanical pumps. And I know that can be a concern for patients who've maybe had it from a different surgeon in the past.
They're all different.
And then they don't get it with this one. They kind of get all up in arms and scared. And some send them home with just like compression socks or compression hose. And that's another way. But activity, getting up, moving, that's a big factor in reducing and blood thinners.
Yeah, and they're going to be prescribed.
Yeah. So if you weren't on a blood thinner before, they'll probably give you aspirin, low dose aspirin, like twice a day.
Yeah.
Okay. All right. All right. So we kind of went over how to prevent them. What happens if you get them? Don't die. Cool.
Yeah.
Call 911, short of breath.
Yeah.
So if there's one suspected, the good thing in home health is we're usually there post-op.
You have a nurse and a therapist coming down most of the time.
Yeah.
Right? Yeah.
I do a lot of therapy only ones, but
Yeah. Okay.
we're usually there every 2 to 3 times a week. So usually every other day during the week, and so we can monitor and tell you if we're concerned about one.
Okay.
If you do get a DVT, you continue doing everything as normal. You will confirm it with an ultrasound. They may up blood thinners. It just depends on whatever your doctor. But it's not a reason to sit and not do anything. That's just going to probably exacerbate or make things worse. So activity is good for you.
Back up some more stuff behind
Probably
it.
the most important thing, activity.
Yep.
All right. Cool. Let's see. Where were we? Oh, this is what y'all were talking about earlier. So once the incision has healed and it's going together, what are the things the patient can do with the scar tissue that's building up? There's different types of scar tissue, keloid, stuff like that.
Mm-hmm.
And then what can they do to possibly minimize the adhesions, which means it's sticking to the bone and whatever. So what do they do? What do you recommend for them?
Super easy, just scar massage, and I usually do it on them the first couple times and teach them.
Make them
You
cry.
hear,
Yeah, make
pretend
them
that
cry.
there's a scar here.
Yep. So like if her incision's here, I usually just tell them, and this is after it's fully healed, I don't let people do it if there's scabs or any opening at all. And I've even kind of tell people to take like an alcohol swab, rub it down the incision. If you feel any burning, then there's some openings, don't do it.
Ooh, good.
That is good.
And that way you're kind of covering yourself too.
Oh, yeah.
But if the incision's here, I usually take either vitamin E oil, Mederma, some kind of lotion, not scented, nothing with irritants in it. And you just push down, and I go up and down the incision in small little.
Along it?
Mhm.
Okay.
Yep, and small little. What am I trying to say? Small little spaced. Yes, thank you. Increments at a time. And then I also will do side to side.
Cross friction, nice.
And then circles up and circles down too. I have had one patient. It's fine if this is the incision, I call it the S pattern to do that.
I'm doing that myself to the patients.
That one's fine. Patients hate you.
Makes them cringe. Yeah.
Hate you.
Yeah, because it is painful.
But it will break up any adhesions, which will give you comfort later. So you can hate us now and love us later.
And more movement, yeah.
That's right.
I have had one person, please don't ever pull apart. Don't do this. It can open your incision.
That's it.
I've had one person that's happened to, and I thought that was a common sense thing, but it's not.
Sense isn't common.
Yeah.
Yeah.
You want to
All right.
maintain that scar.
All right.
As it is.
I used to always tell people, the patients whenever we're sitting there and I was talking to them, they're like, why is it stuck? And stuff like that, because they hadn't done anything.
Well, and a lot of people don't know about it.
And well, they don't know about it. They come see me later. This is whenever I was working at the clinic, and they wouldn't be there till after they've been at the house for 6 weeks, not doing anything.
Yeah.
And but scar tissue doesn't care. It's going to
No.
stick to anything it can. Bone, patella. I mean,
And that's what it does. So when you have a surgery, scar tissue or injury, your scar tissue just kind of goes like this. It's trying to heal that area. And what Katie was saying, when you do that massage, you go back and forth, you break it up, you're making that scar tissue align with the muscle fibers so that it can move freely under the skin.
Which means it doesn't restrict your mobility.
Right.
Or it reduces your pain with mobility.
Exactly.
An add-on to that too, dose it for the people. Tell them how long to do it. I usually just say about 5 minutes once a day. Like just do it once a day, because there will be people who will want to do it for. And they, I had one come back and it was like super red and irritated. I'm like, how much are you doing? I do it like 5 times a day. I'm like,
I was using a stick.
Yeah. Let's back off of that.
All right.
Okay. So, typical healing time to get back to your normal daily living activities.
Okay, it's a fun question. Yeah. Probably one of my least favorite, just because it's.
You're talking about all the way back to taking care of yourself, cooking dinner for the husband, or going out to barbecue and drinking beer to the guy.
To a point where they're able to kind of do their own thing without having help from home health.
Where they can fire her.
Where they can, kind of like where they can start driving, where they can start doing their
ADLs.
What is ADLs? What is that? What's an ADL?
The active daily living.
Activities
of daily living. Yep.
So I'm like an OT now. Go ahead.
Either way, OTs.
Okay. Normal time back to normal.
Healing time.
So typically, I am fired at home health about. Depends on a knee, typically 2 to 3 weeks of home health, and then they usually go to outpatient. A hip is really pretty short and sweet. I see those maybe for 2 weeks. Then they usually either continue with their home program and then go to outpatient. It just depends on the surgeon. But I mean, the healing process of these surgeries, and it depends on what surgery you have. It can be up to a full year to gain your full strength back, which is what I tell people, because they expect to be back in a month. Normal.
Yeah.
And there may be a guy who works in some kind of factory line who's on his feet on concrete 50 hours a week. So I would say on average doing things normal in your home, or like being able to take care of yourself, 6 to 8 weeks probably. I'd say 3 to 4 months you feel pretty good. You may have to take a rest every once in a while with more activity.
We're going shopping.
But other than that, it can take several months. And something else too that people don't expect maybe is that swelling can go on and off for up to 9 months to a year. If they've done a lot of activity, they can have some swelling in the knee or whatever. And it's usually just activity dependent, so it's kind of a vague answer.
I think that's good.
You can't give it a real umbrella term. I mean, I always say 6 to 8 weeks, bro, and then sometimes it's 12.
And that's usually when the scar completely heals and you're up and moving.
Yeah.
Right?
Mm-hmm.
But to be like prior level, it all depends.
Yeah, and we've been talking about replacements and stuff like that. What about ACL? Somebody get ACL replacement. How long is that till you're back to play?
When I had my ACL done, which was 2004, 5, something like that, kind of the gold standard then was 6 months of rehab. Now they've shown, it's more like 9, 10 months of rehab.
You should go back to the front. Right?
Yeah, if you want reduced rates of re-tear of an ACL, you shouldn't go back until closer to that, probably a year post-op. So it's a long process to get to know your therapist well.
And you might not be even at your full
capacity,
butt kicking at that time. Mm-hmm. Yeah, so you gotta be careful. Cool.
Yeah, well, and we were talking about, like you said, the inflammation kind of comes up and down depending on activity. I think that's a big thing that people need to realize is that with pain as well, because like you can tolerate something and then you're feeling really good one day and you're doing more and your therapist is giving you a little harder exercises. That next day you should expect some inflammation and maybe some a little more pain with it.
Yeah, and that's why it's good to have a therapist guide you through these things, because you know, they don't know. A lot of people have that increased swelling, increased pain, and think, oh, something's wrong, I messed something up.
Yeah.
And usually it's not the case, it's just you loaded it too much, there's an inflammatory response, you get back off for a few days. So it's good to have somebody who's experienced to guide you through those things. And if I can add one more thing.
Yeah.
A surgeon explained it to me when I worked in the outpatient sports setting, because being a first year, you learn a lot in school, but being a first year and being out, you
realize you don't know a lot.
I don't know what I'm doing. So he explained it to me, you know, the healing timeline, and he said if you try to make everything pain-free, smooth, everything is super comfortable during therapy, you're going to get to the end point, but it's going to take you forever and a day. If you go through those, you know, you're doing well, you load it, you kind of see where your limits are. And you give those loads, introduce those loads, you're going to have a curve where you'll do well, you'll load it, and then you'll have to back off for a couple days, and then you come back up. So you can get back to your function quicker, but there's going to be ups and downs, which are normal to expect.
Yeah.
Very good, very good.
But a lot of patients don't know that, so it's just good information to put out there.
Mm-hmm.
Okay.
All right. Is that it? That's all our questions?
I think so. Okay, anything else that...
Hang on, we got questions from the audience.
Okay.
Right?
Well, while you get those up...
I got them. I pulled them up. All right. So, a good friend of ours, I'm going to say her name, Trisha. I won't say her last name, but so we worked with her for a long time, and she is a avid triathlete, and she does Tough Mudders. She's hardcore.
She's just active.
Yeah,
she's very active.
Yeah. So she tore her ACL, and she said she's currently on the fence regarding ACL surgery. I think if I want to run consistently again, I'll need surgery. There are too many variables to form a good question, but if y'all had any experience with recovery without surgery, I'd like your input.
Well, I'm going to say hands down, yes, needs to have the surgery. Just based on activity level. There's copers and non-copers. Copers meaning you can deal with the ACL tear not having it fixed and still be functional. However,
but when you're doing what she does,
yes, at her activity level, I would say needs to have the surgery. If it were me and I was at that activity level, I'd have it.
Yeah, because
exactly.
it's uneven surfaces, and that's when you really need like the stability of your knee to hold you up.
Well, I don't think people get sometimes, because it's a commitment when you have an ACL reconstruction, because you know if you want to do it right, you're gonna have to do a lot of rehab. But you know that ACL provides stability to your knee. If you don't have that, there's a lot of extra play in the knee, which can shred the meniscus, which is cartilage in the knee, and lead to further problems. So.
Okay. Well, I know there people are like, well, his name Dijon Blair, whatever his name is, the NBA player. Mm-hmm. He didn't have ACL. Mm-hmm. He played freaking NBA, but that's like the 1 in a million, right? People are trying to say that, but when you're running off road, you're climbing obstacles, you're jumping over things. There's no point in not doing it whenever they have some good outcomes from it. I myself, if I was going to have one done, I would do an autograft. Mm-hmm. That means I'll get a cadaver.
So there's two different kinds.
Yeah, I would get somebody's freaking Achilles tendon in my knee. It's nice and strong, and ain't going anywhere.
Instead of taking like your Achilles tendon or your hamstring tendon.
Or like some people go and get something out of your patella.
I had a hamstring whenever I had mine done. So I had part of my hamstring taken. And I recovered fine, but I can
it takes a while, right?
Still to this day, well, I have kids, life don't work out like I used to. So I can tell that there's still a little bit of deficit hamstring wise, strength wise, and that's been over how many years? High school, that's a long time ago.
Yeah. All right, well there you go, Trish. after surgery.
Sorry.
Yeah.
But, yep.
Yeah.
All right.
Mhm.
And don't take it out of your hamstring. You ripped it. All right.
Yeah, or your patella.
I had somebody do the patellar tendon. I
That would
heard
cause
about
so
it. I never saw it before, but I saw a kid come in. He was in so much pain, and he was in the military. You know they have, and he was infantry. They have to low crawl. You're never going to put pressure on that knee again. So don't do that one. It's up to you. Research it on your own. I would do an Achilles tendon.
Consult these two.
All right. All right. Very good. Or Katie. All right. So the next question is from Jesse.
Okay.
Coolest fireman in the world. He says, "Good to see y'all two are doing amazing things for people. My question is, what would you like to see in pediatric sports or education? My daughter tore her ACL, and her PT said a lot of these type of injuries could be prevented had kids been taught how to properly move. Is that true? Takes it in advance and take care." So, and I think, I don't know how. I didn't ask him how she wound up tearing it, but definitely can be prevented. But how can they not be prevented? What would have happened if she would, for that?
Like, what can you do to try to help prevent?
Well, I think what you're asking is ACL surgeries or ACL tears. There is a portion of people that whatever that incident happened, it could not have been prevented.
What mechanism of injury is not preventative? How's that, first off?
Oh, like contact or
yeah.
And that's how I tore mine. Went up for a layup, got hit by somebody in the knee.
Yeah, usually it's that coming from the lateral side.
That's the outside.
Hitting the knee, hitting the outside of the knee, and your foot's planted and it twists it in.
Yeah.
Just pop it right open.
Yep.
And you see that in football, guys get hit right there, boom.
And that's
But majority of them happen with non-contact. It's just poor movement patterns.
So is that preventable?
Yeah.
Okay.
And I would say that, I've been out of school for a while, but I would say that the typical weight room workouts that you do during athletics don't focus on like the hip abductors, which are the outside of the hips. They work on that side-to-side motion. They don't work on proper squatting patterns. They want to load, add more weight so you're stronger, but sacrifice form.
So doing my quad extensions, my knee extensions to get my quads real big, ain't gonna help.
Well, it's not super functional either.
Before we kick somebody else.
Super hard. Super hard. So yes, I do think that there are exercises or groups, and I think y'all will probably talk to somebody in sport.
So
we're gonna do some videos.
Next week we're gonna do a video on common patterns that are seen in most female athletes, but this does not just pertain to female athletes. It goes across the board on activity, whoever's doing it. So we're gonna go over.
It's gender neutral.
Yeah. We're going over squats, single leg squats, jumping, landing, and then just maybe a couple of drills and things to go over.
Deal with.
And we also know a therapist that is like pediatric orthopedic.
Yes.
Like that's her specialty.
She does camps.
And they do camps in the summer. And I think that's a big thing is preventative care for these athletes, young athletes. Like it's sad that you are spending your entire high school career trying to be that main athlete and then you get an injury and you're done.
It's not, but the problem is, that's one of the problems. I get on soapbox with these parents that want to live vicariously through their kids, and they have them in, I want my kid to be a pitcher. So they got their kid pitching all year round, not just in, club and not just in Little League. Then they got a freaking pitching coach. And nobody cares about this kid. And the kid comes to see me and his shoulder blade sticking straight out his back like that. And he's in pain. And I say, "You sure you want to pitch?" He said, "No, I don't want to pitch anymore."
Yeah.
His dad never heard it. He won't tell his dad.
Yeah. But they'll confide in therapists, especially if you get them by themselves.
So this training, this specification, you need to find somebody that can help strengthen the kid appropriately.
Yes.
If you want to do that.
Yes.
And I would pay 5 times more to go to a ACL prevention camp or a movement pattern camp versus just the volleyball one and basketball
and pay some coach to make sure that if you want to you decrease the amount of injuries your kid's going to have in the future and actually give them a chance at college education for free, you better pay somebody that can keep them strong, keep them keep them from getting injured. Or
And
else you can lose it.
when I worked in, because I saw a lot of middle school, high school athletes, but we were seeing younger and younger and younger severe injuries in 8 to 10-year-olds because they do competitive gymnastics.
8 to 10-year-olds just need to be playing.
Yeah.
Everything.
Exercise should be fun.
Yeah.
Yeah, absolutely. Okay, cool.
Okay.
I think
that was really good. We kind of went off a little bit, but that was great.
Tangents are great.
It is. It's very informative. Thank you, sweetheart.
Wow,
Thank
you're
you.
all set.
I know.
She has a whole basketball.
Sorry for that.
I know.
To get going, I like
No, it's good because
We're
this is something that I think all three of us are pretty.
So-
Wait. I think this is something that we're all passionate about. Kind of that preventative care and like just that performance, that whole body performance. I think it's so important. So yeah, that's why we kind of go on. Yeah.
Okay, so a bonus question.
Yep.
So besides being an awesome physical therapist and mother of 2 and a wife of 1, right?
Just one.
Is there anything else that you're doing right now? Anything in the world that you're doing that you are passionate about and have fun doing?
Yeah. So I have with my family, my sister and my dad have a business called Try Texas Stitch. So look us up on Facebook, Instagram.
TRY?
TRI, Texas, and then Stitch.
Okay.
So we do embroidery.
You have Instagram?
Yeah, we do have Instagram and Facebook.
All right, we'll put that in the show notes too.
So they can link it.
Yeah.
But we do embroidery, and it's just something different and something fun. You have sometimes I care so much about my patients that sometimes you just get you just need an outlet that's like you don't have to think. It's just something fun. And so we do embroidery.
I know
so
you've
if you
already
need
got
anything,
cool
check
stuff
us
like
out.
Yeah, so we're gonna order maybe some hats and some shirts, and we'll start wearing them in our in our YouTube. So
Yeah, perfect.
we'll mark it. So well, thank you, Katie, for your time.
Thanks for having me.
Yeah. Well, thanks for having us. Cause
Our kids are tearing our house up right now while we're here,
yeah.
as you can tell.
Well, my kids are gone.
Yes.
It works out that way.
All right. Well, thank y'all.
Yeah. Thank you.
Happy Thanksgiving.
Happy Thanksgiving. Make sure you subscribe and like and press that little bell for any new videos.
That way you get notified whenever that happens.
And I think we're gonna do one tomorrow on Thanksgiving.
Oh, we're gonna do it with the impressive Vic Zachary.
Oh.
Yeah, Ninja Warrior.
Stay tuned. That'll be
Yeah. Stay tuned. So, happy Thanksgiving.
Bye.
See you. Bye.